Okay. So the question here is which of the following actions of pharmacokinetics is most impacted by age? And we've already defined pharmacokinetics as the way medications move through the body. And so absorption, distribution, metabolism, and excretion were the options, and you pick metabolism, which is right. The older a body is, the less likely it is to be able to metabolize the medication well. And even so much so that if you gave them a big high dose, it would like be stuck in their body for days, right? Whereas me and you, if we took a medication, it might be in and out of our body in like 6 hours, depending on the medication. But for elderly people, it could take maybe 3 days. And now they're not getting the full impact, or they can even overdose because if they keep taking it every day like they're supposed to, but it's a high dose, it now stays backed up in the system. It can cause an issue because they can't metabolize it well. Excretion is just your body's ability to remove medication, just pee it out or poop it out. Age does not play a significant role in that. Maybe if I had an issue with my kidneys or an issue with my gastrointestinal system, like maybe I had colon cancer or something, or if I had, oh, here's a good one. If I had Crohn's disease. Crohn's, if you remember, we talked about Crohn's disease a few times ago. Crohn's disease is like the intestines are so irritated that as soon as a person eats food, within minutes they're pooping it out. Every time they eat, they poop it out, they poop it out. It's just irritated. So can they ever absorb anything? No,
Mm-mm.
because it's just passing straight through them. So they're going to have an excretion issue. So therefore, even the pill, they can literally poop out a whole pill because their body
Mm.
never got a chance to absorb it correctly, which is really absorption now that I'm saying this out loud. But the primary factor to impact speed of absorption includes the route the medication was taken. Remember, if you swallow a pill or if you put it under your tongue, sublingual, which one's going to affect you quicker?
If you put it under your tongue,
Exactly. If you do a sublingual pill, it's gonna, within minutes, it'll be in your system. But if I swallow it, it can take 45 minutes to an hour. So that really has nothing to do with age. It just has to do with the way I received it or if I have some type of issue with my body. And then distribution is not impacted by age either, because this is basically how the medication is moved through the body and through the blood into the brain. And so, in even women who have a placenta when they're pregnant, how it can get to the baby. That's distribution. Your age has nothing to do with your distribution, just your metabolism. So very good. All right, next question. And remember, this topics that we're doing is the foundational knowledge and basic science concepts of medical assisting. Which of the following is the first step a patient who has stage one chronic kidney disease should take to app their diet? Before we get into this, do you know how many stages of kidney disease there are?
um, three.
I believe it's four,
Mm.
but let me confirm. Yep. Oh no, they have five. There's five stages of kidney disease. So the first one is just stage one is just a small damage, right? And then it goes, stage two is a mild, stage three is moderate, stage four is severe, and stage five is end stage renal disease, meaning the kidneys don't work at all. This person, they're lucky if they make 15 milliliters of pee a
Mm.
day, like a small, that's just drops. So, but this is stage one. So this is the very beginning stage of chronic kidney disease. It says, which of the following is the first step a patient who has stage one chronic kidney disease should take to adapt their diet? Should they have low sodium, decrease their phosphorus intake, control their potassium intake, or avoid gluten products? So I want us to think about out of these four answers, what two do we know for a fact are not the answer?
B and D.
Okay, so you don't like B and you don't like D. I'm with you on D. Okay. And then so if that's the case, that would leave you one, sorry, A and C. So I remember I always go back to the question. Which of the following is the first step a patient who has stage 1 kidney disease should take to adapt their diet? And again, this is the first step. So now that we have these two, which one on test day would you pick?
So, let me think. I don't know. I don't know if you're because control and limit is like two different
Mm-hmm.
kind of words. Control. Mm, I would probably, I would probably went with A.
You'd have probably went with A. Okay, so let's pick A and see what happens. Very good,
Mm,
Anaya. So it says here, high blood pressure is the primary contributing factor to kidney disease. That's the third time I've said that today now, right? High
hmm.
blood pressure is the primary factor to kidney disease. So, what is the number one thing that causes high blood pressure?
The kidney disease.
Sodium.
Oh, the sodium, yeah.
Yep, sodium is the number one thing that causes high blood pressure. And let me remind you why. Water and salt are best friends. Everywhere that salt goes, water wants to be. So if you, just like you drink that water, right? And then you drink, let's say, a spoonful of salt, water will automatically attach to that salt, and everywhere salt goes, it wants to go. When it makes its way to the kidneys, the kidneys are supposed to say, hey, salt, this was too much salt. I had a spoonful, but I only needed like 3 grains. So it'll make all the rest of the um, sodium, the salt, go away. And what's the water going to do? It's going to follow it because they're best friends. But if I have kidney disease and my kidneys are like, man, I know I got too much salt, but I'm not strong enough to get rid of all this salt. I can only get rid of half of it. So the other half gets to stay. That means the half of that water got to stay also.
Mm.
The more water you have in your blood, the higher the what?
Oh,
And the higher your blood pressure.
oh, yeah.
Because water and salt all live inside of your blood. So the more you have, the more it's going to be pressure inside of your veins. So it's just like it's a trickle down effect. More sodium means more water in your veins, means the higher the blood pressure. The higher the blood pressure, the more pressure goes into your kidneys, and now your kidneys stop working as well. So if the person limits their sodium intake, because we know that that's the number one cause of high blood pressure, a patient who has chronic kidney disease should limit their sodium intake to less than 23 milligrams per day. Very important to know, because you're going to be telling the patient that you shouldn't be having any more than 23 grams of sodium a day. How am I supposed to know it's only 23 grams? Okay, look at the packages. Every package tells you how much sodium was in it. So every time you eat something, look at the package. Now, phosphorus is important, but it's only important when
Stage, what was that?
stage
Four
4
and
and
five.
5. So decreasing phosphorus intake is indicated for patients who are in stage 4 and 5 of chronic kidney disease because worsened kidney function leads to higher levels of phosphorus in the blood. Remember, your kidneys are responsible for saying, hey, you got too much phosphorus, you got too much potassium, you got too much sodium, we got to get rid of this. But when your kidneys are not working properly, like in stage 4 and 5, they can't do that. So when they can't do it, where does the phosphorus and the sodium, the potassium stay? Where does it stay?
In the blood.
In the blood, exactly. And then it backs up and it becomes too much, and then it can hurt the person. Same thing with potassium. Controlling potassium is indicated for patients who have stage 4 and 5 because the worse the kidney gets, it leads to them increasing the potassium in the bloodstream. I do want to say this, potassium is probably the biggest problem with kidney disease because if you remember or recall, What do they give people for lethal injection to kill them?
Potassium.
They give them potassium. Okay. If you ever heard of a person going to lethal injection to be killed, they are given potassium straight in the IV.
Mm.
And by the time it makes it to the heart, too much potassium in the heart makes it have a heart attack. That's how they die. They basically are inducing a heart attack on those people.
So that means we have to look out for potassium. Is that on the back of packages?
It is on the back of packages, but it doesn't matter. We can have as much potassium as you and I want because our kidneys are okay. They know how to get rid of it. Yeah, your kidneys are gonna say, you know what, this was too much potassium, let
Mm.
me pee it out. But remember, if you have chronic kidney disease, stage 4 or 5, your kidneys don't work and they don't know to get rid of it. Now, this isn't to say that me and you can't die from potassium overdose. We can die, but it has to be like a lethal amount all at one time. There's no banana that's going to do that, right? So yeah, it would have to be a lethal amount all at one time, but that, yes, it can definitely kill a person.
Mm.
And then avoiding products, gluten, that's for celiac disease. Gluten has nothing to do with the kidney at all. Remember, celiac is inside of the intestines.
Mm.
All right. So back to the question, which of the following is the first step to a patient who has stage 1 kidney disease? And with their diet, the first step is limiting the sodium. Very good. Which of the following forms of medication are delivered orally?
I don't know what C is. I'm not really too sure what A is either. I mean, no, I don't know. Um,
Well, let's break it down. Have I ever taught you anything about like foam medication?
mm-mm,
No.
no,
So we know that that's probably not it. Mist is just a what? A spray.
spray.
We know what powders are, right?
Hmm.
Think of like the BC powder.
Yeah.
Okay. And then a lozenge. A lozenge is just like a cough drop.
Oh, okay.
Yeah, it's just something you put in your mouth and you suck on over time. So it says, which of the following forms of medications are delivered orally?
I would have picked D.
Okay. All right. And
See,
so
I thought about that, but I didn't know cough drops was a considered a
I'm
medication.
with you on that. I'm with you on that. So let's read all the answers so that because remember, sometimes the answers, like right now, this is just the test to prepare you for the NHA exam, but they may have something the opposite direction. Like it might say on the test, which of the following medications are given vaginally, right? And then you're looking and you're like, I don't know what any of these, but it just told you right here in the prep.
Mm.
Foams are delivered vaginally, okay? Mists are delivered through the nasal route or through inhalation. Now, I'm with you because BC powder, I mean, come on. But it's saying that but that is true. Most powder medications are delivered topically on the skin. So I'll give you an
Powder?
example. Oh yeah, we give it a lot for like in the
Oh,
hospital. I know you've seen it, like the yeast medicine that goes in people's folds.
yeah,
That's a
yeah.
powder. Mm-hmm.
That's what I thought of immediately, but this
No, me saying BC
questions,
powder didn't make it no better, so I'm sorry.
but like it could go both ways,
Hmm.
so but I get it, I guess.
Yeah. And then I'm with you. Lozenge, like I'm trying to think of a medication I've ever given that was a lozenge. I can't think of one, but
I
it would
mean,
be
there's like tablets, I guess, that you could chew on. Is that same thing?
hmm But here's also the difference. The BC powder is not oral, it's sublingual.
Mm,
So that's also the difference there too.
uh,
Yeah, BC powder is supposed to go under the tongue.
okay.
Which of the following actions describe the medical assistant's role in confirming the right medication in terms of medication administration? So remember, before you give medication, they usually teach you there's quote unquote, I think 5 rights. I think they have more now. But the 5 rights are the right medication, the right person, the right dose, the right time, and the right route. I'm going to say it again. The right medication, the right dose, the right person, the right time, and the right route. So the question says, which of the following actions describe the medical assistant's role in confirming the right medication in terms of medication administration? Is it assessing the benefits and risk of the medication? Is it stating the name of the medication, who ordered it, and the intended effect of the medication? Is it informing the patient of the medication? I'm sorry, informing the patient of the indication for the medication or evaluating the patient for effects? What does the right medication mean?
Mm, mm. I mean, like I would put B.
Okay, very good. Tell me what two you knew for a fact it wasn't.
Not D. And I guess I would have probably ruled out C too.
Yep. Because it's kind of like a conversation you're having with yourself. The five rights are a conversation you're having with yourself before you even give it to the patient, right?
Hmm.
And so then that left these two for you, and then you picked that one. Okay, got you. So very good, Anaya. That's the right answer. The role of the medical assistant in medication administration is to say, is this the right medication? Meaning, is it the right name? Is this the right person who ordered it? And what are we even giving it for? Like just because I told you to give a patient carvedilol, you have to ask yourself, why am I giving carvedilol? Does this patient truly have a heart issue? Because if they don't, then why am I giving it? That's left up to you to think about. And then if you're supposed to question that, you're supposed to go back to the provider and say, hey, I noticed you ordered carvedilol for this patient, but I don't see that they have any heart issues. Are you sure that's what you meant to order? And I might say, oh, I meant carvedilol, right, instead. And you're like, okay, not the carvedilol is a medication. I'm just making that one up. But sometimes they sound so similar that something like that could happen. All right. The other answers were assessing the benefit and risk of the medication. It says while medical assistants can be authorized to administer medications, it is not within their scope of practice to determine if a medication is appropriate for a patient based on the benefit versus the risk. That's up to the doctor or the provider.
Hmm.
Informing the patient for the indication of the medication, while informing the patient of the indication for the medication is your responsibility. This actually relates to the concept of the right reason for the medication, not the right medication. And then next, evaluating the patient for effects. While evaluating the patient for effects of the medication and any reactions to the medication may be the responsibility of the medical assistant. This relates to the right evaluation rather than the right medication. And so remember I told you, like, so back in my day, there were five rights, but I think now they have six or seven because now they're talking about the right reason for the medication and then the right evaluation. Like after you give it to them, watch them. Which of the following allied health professionals should a medical assistant initiate a referral to for a provider who has ordered support to assist with improving the patient's range of motion? Ooh, they made that question long. I'm gonna read it one more
Hmm.
time. Which of the following allied health professionals should a medical assistant initiate a referral to for a provider who ordered support um, to assist with improving a patient's range of motion?
I should know this, but like, I mean, I think I know it.
Okay,
I
what you
think
think?
it's B, but it could be D too.
You think it's B, but it could be D. Very good. Because number one, a radiologist ain't got nothing to do with range of motion unless we're just doing an X-ray. And
Hmm.
then a nurse practitioner would be the person making this request, right?
Hmm.
So that's the one you like.
See, I need to know the difference between the
Yep,
two.
exactly. So Let's figure that out right now. Physical therapist, you would initiate referral to a physical therapist to assist patients with building strength and increasing range of motion. Occupational therapists um, assist patients who have developed conditions that restrict them developmentally, emotionally, mentally, and physically. I don't like that answer.
Yeah, I thought the OT people do range of motion and stuff too.
You know, I had an OT explain to me one time. He said physical therapists do the bottom, occupational therapists do the top. That's how he explained it to me. But let's do
Oh,
this
wait,
real.
he said, what did he say to
Hold
you?
on. I don't want to repeat it if I'm wrong. Hold on. Yeah. Okay. So the difference between OT and PT. So OT is more of the fine motor skills, like self-care. That's the top, how he said the top. So OT, he told me OT is usually for the top of the body. So like, can I feed myself? Can I brush my hair? Can I put my contacts in my eyes? Stuff like that. As you see here, it does also say emotional regulation, but that comes from the mind. So that's still the upper part of the body. And then over here, PT is more gross motor, like lower limb alignment, like can I walk, the bottom part of the body, gait training, helping them ambulate, helping them with flexibility and posture. And yeah, so fine motor, I always think of these two fingers whenever I think of fine. And when I think of gross motor, I just think of like using my whole hand, like to grip, if that makes sense. So fine motor just means like the itty bitty abilities. Now they say
Mhm.
together, PT and OT help with motor skills, eye-hand coordination, and so on. But yeah, OT is the top part of the body, PT is the bottom part. That's the best way.
Okay.
So the answer was physical therapy. Let me go back to the question. Which of the following allied healthcare professionals should a medical assistant initiate referral to support a person with range of motion? It's physical therapy.
But what about range of motion in the arms?
Of the arm. Yeah, that's true. But think of the arms
Oh, as like, okay.
fine
Yeah.
motor. Think of it fine motor in the fingers. Like we're not using our toes to eat, right? So
Mm,
the fine
that's
motor is
true.
more with the fingers.
Okay, yeah, I get it.
Which of the following statements describes patient-centered medical home?
Patience.
Tell me which two you don't like.
Mm, um, sorry, my dog.
It's okay.
Okay, everything. I don't, maybe not the patient center medical home.
So what is a PCMH, first of all? What is a
Yeah,
patient-centered medical home?
it's a good question. I don't really know.
It's literally what it says. It's kind of like everything the patient needs is all in one place and it's all patient-centered. meaning
Oh,
like we
yeah.
everything that we do is based upon the patient's needs, whether it be mentally, physically, emotionally. It like touches everything that the patient could need all in one place. So now that we know that, as we read through the answers, it is an umbrella term for plans that provide health care in return for preset scheduled payments and care coordination. Do you like that? Yes or no?
Mm,
Or maybe. I'm sorry. Yes, no, or maybe.
I guess so. Not really, but I guess.
Okay, so it'll be a maybe. It is a care delivery model supported by an interdisciplinary team and led by a primary care provider. What is an interdisciplinary team?
Um, like, I guess people to make sure you're doing what you're supposed to be doing.
So interdisciplinary team could be like a dietitian to make sure you eating good, a physical therapist to make sure you can walk good, a occupational therapist to make sure you got good fine motor skills. It can be a speech therapist because you had a stroke, so now you need to learn how to talk again. It could be a psychologist because you have mental issues. Those are all the interdisciplinary team. We all work on the patient together. Yes, no, or maybe.
Yes.
Okay. So we like one and two. Next one. It is a nursing care and therapy delivered to a patient in their home following an acute event.
Yes.
Okay, we like that one. And then the last one. It is an inpatient care facility for patients who are at end of life.
I guess no.
No, because that's hospice,
Yeah. Okay.
right? Okay, so of these three, if you had to pick one, which one would you say describes a patient-centered medical home?
Either B or C.
Okay, let's pick B.
Wait, don't. Okay, this weekend.
It is B.
Oh, okay.
Okay. So it's B because the PCM model is a care delivery model in which the primary care provider coordinates all the treatments to make sure the patients receive the required care when and where they need it and in any way they can understand. So it doesn't necessarily have to be inpatient or outpatient or whatever. None of that matters. All that matters is there's a leader and then there's a whole bunch of people who are all there to give the patient what they need. Hence the word patient-centered.
Mhm.
Now let's read the other ones. This one, managed care is an umbrella term for plans. So that's just a plan like an insurance plan, right? So it has nothing to do with an actual care delivery model. And then this one that you thought it might have been, this is more home health because they're going to their home. So let's say like I had a stroke and I was in the hospital, but now I get to go home, right? So that's an acute event. But I'm home. I can still do stuff, but I kind of need help every once in a while. So home health refers to specific type of care, typically physical therapy or occupational therapy or even nursing being provided in a home because they are unable to leave their home easily. I can't walk, I can't drive because I'm all flaccid on one side, right? And then this last one, as I mentioned to you, is hospice, is end of care. So I'm going to tell you this. We have seen this question about patient-centered medical care homes at least 5 times. I can 100% guarantee you it's going to be on the NHA.
Okay.
What you need to remember about it is that it means everybody comes together and cares for the patient wherever they are. And as you see, there's a leader who coordinates the care, but it's everybody coming together to make sure it's patient-centered. Which of the following schedules of controlled medications can be prescribed with up to a year's worth of refills if authorized by the provider? There's no way you're going to know this because we haven't went over this.
Yeah, I was about to say, I would have
But
guessed on this.
let's go ahead and go over it. So you have schedule 2, 3. This is 2, 3, 4, and 5. I didn't mean to click that. So there's different schedules of medications. So it's important for you to know those schedules of medications. I'm gonna tell you right now, it ain't Schedule 2.
Mm,
Schedule 2 are like hardcore drugs. So the DEA, which stands for the Drug Enforcement Administration, they are America's like company that says how drugs are done. Schedule 1, which was not on there, these are illegal substances like heroin, marijuana, those types of drugs, meth. Those are all Schedule 1 drugs. Schedule 2 drugs, which are right behind it, these are the legal drugs, but they're just like Schedule 1. They're addictive, they can kill you, blah, blah, blah. So these are Schedule 2 drugs are things like morphine, Dilaudid, methadone, Oxycontin, fentanyl, all of this stuff. Those are Schedule 2 drugs. So remember the question. The question says you can give a person a year refill worth of this medication. Do you think we would do that for this?
mm,
No. We usually only give a patient maybe 15 days at the most, 30 of these medications, and then they got to come back to us because we got to make sure that they're not addicted. All right, Schedule 3. Schedule 3 drugs are substances with a moderate to low physical and psychological dependence. So some of these drugs, Schedule 3, like ketamine, testosterone, codeine, and so on. Do you think that this would be a medication that you can give a
yes.
year's worth that you could give a year's worth of refills on?
Yes.
The answer is no, because codeine, I don't know, are you familiar with codeine?
Mm,
They talk like
mm,
codeine is like in the syrup. They have like codeine syrups, and people are always talking about drinking syrup and all of that, the cough syrup to get high.
um,
That is a very highly addictive medication. Also, testosterone. A lot of times men will inject themselves with testosterone to try to make their muscles grow and make them stronger.
mm,
Ketamine is a drug used to kind of like tranquilize people. So again, these medications are highly addictive. They're moderately, we'll say that, moderately addictive. Therefore, we should not be given a whole year's worth of this medication. All right, Schedule 4 are Xanax. We already know the answer to this, right? No, you should
mm.
not be giving anybody Xanax for a year, period. Are you familiar with Xanax?
Yeah.
Mm-hmm. And then Schedule 5 drugs are drugs that have a low potential for abuse. Okay. Very low. So this is things like Lyrica, Lamotil. Lamotil is like a medication that you give a person who got diarrhea. Um,
Mm,
Lyrica we use for nerve pain and so on. So yeah. So now that we know the difference between the schedules 1, 2, and 3, 4, and 5, which of the following controlled schedules of controlled medications can be prescribed with up to 1 year's worth of refills if authorized? Which one would you say?
5.
Yep, I would go with 5 too. All right, and that's the answer. This is the least controlled of the drugs. Providers can give them a whole year if they want. This is good to know. Schedule 2 and 3. It says Schedule 2, Schedule 2 is never refills, which is true. They got to come back in. But Schedule 3, they could get up to 5 refills, so that's 6 months worth. 5 refills, which is 6 months worth, but this one they can get a year. Which of the following is a warning sign for anorexia and should be reported to a provider immediately?
A.
Okay. Tell me your thought process as you read through all of these.
Well, if I thought anorexia means like skinny,
Hmm.
so excessive exercising wouldn't be it. Well, hmm, um, if they're exercising a lot, Oh, that might be it too. But never mind. So buying and consuming large amounts of food, that's not it, because they wouldn't be eating increased frequency of menstrual periods. I mean, I don't know, but since I don't know, I would have eliminated it. That
Okay.
one.
So you would have eliminated these two, and then it just would have been between one A and D, right?
Hmm.
Which is very good. Now, of A and D, because I agree with you, these two are automatically ruled out. Now that you have A and D, it's test day. Which one are you going to pick?
I mean, I kind of want to pick A because excessive exercising, I mean, I guess they would consider that a warning sign, but I wouldn't necessarily categorize it as a warning sign because if I do working out excessively, I don't wouldn't consider that anorexia.
Okay.
I
So,
mean, I don't know.
so which of the following is a warning sign for anorexia and should be reported to a provider immediately? So, weight loss of at least 5% or excessive exercising.
It's probably D, but I would have picked A.
Okay, let's pick A if you'd have picked A. Yep.
Yeah, I had a feeling they would go by the
Yes.
books on that one, but I mean, I wouldn't categorize that as being anorexia.
I guess it's only anorexia if other things are present, right? Like the person is underweight already, and then they're telling
Oh
you they're
yeah,
excessively
exactly.
exercising, but that's not what the question said, to be fair.
Mm,
It didn't say that. But just know for NHA purposes, they said a weight loss of at least 15% is a potential warning sign for anorexia, not 5. Now, these two right here are important to talk about. Um, First of all, let's define anorexia. Anorexia is basically a person who is skinny, like you said, but they're underweight skinny and they don't eat, or if they do eat, they eat like carrots and stuff that's not does not have calories, and they do typically over exercise. Okay. Now, it says increased frequency of menstrual periods. Actually, people who have anorexia don't have periods.
mm,
So that's what's called amenorrhea. Remember, A always means without, and then menorrhea means a menstrual cycle. So typically, people who have anorexia have amenorrhea or a lack of a menstrual cycle. That is the potential warning of anorexia. And do you know why they have no period?
um, maybe because of the lack of. I'm sure it don't have nothing to do with it, but I would guess like lack of food and nutrition and stuff like that. I
It's
guess.
basically the lack of fat.
Um,
Mhm. Fun fact to know. The more fat you have on your body, the more likely you are to have a period. The less amount of fat you have, the less likely you are to have a period. So, a lot of these young girls, like a lot of it, like when I was young, you would start your period at 12 or 13, maybe even 14. But now a lot of these young girls are starting their periods at 8, 9, and
mm,
10, and that's because they're overweight.
mm,
The bigger you are, the fat cells have estrogen in them. And the more fat cells you have, the more estrogen you have, and estrogen is responsible for your period. Estrogen is also responsible for cancer. So, just that's something to know also. So, anyway, being overweight would actually give you a period sooner than you were supposed to. But when you lack fat, means you're lacking estrogen, which means you won't be able to have a period. So, a lot of women who are athletes and who run and do all that stuff, they're not necessarily anorexic. They're thick, but it's muscle and not fat. A lot of runners lose their periods because they don't have any fat. It's all muscle.
mm.
All right, and then we have this one. Buying and consuming large amounts of food is actually a sign of bulimia. If you are underweight, but you are like pigging out nonstop, but you never gain weight, they're probably throwing it up immediately after. So bulimia is a person who eats, 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 and then the privacy and quiet, they go and throw it all up. They want to eat, they like to eat, but they don't want to gain the weight, so they vomit.
Mm.
And then excessive exercising was the answer. That is a warning sign of potential anorexia. All right, a patient calls in with a question about one of their medications but does not remember the name of the medication. They tell you it's a small oval-shaped pink pill. The patient's medical record indicates that they are currently taking 10 medications. Which of the following actions should you, as the medical assistant, take? I want you to tell me the two that you know for a fact are not the answer.
It's not B.
Okay, what other one don't you like?
Mm, um, I don't know either C or D. Is bringing medication in wrong? Mm,
It's not. We typically ask the patient all the time to bring, like every time you come into a visit, if you can, bring your medication bottles with you. We ask
that's
them
what I
that
was thinking.
because
So
a
I
lot of
guess
times they
B and
don't know what
D.
they're taking.
So I guess B and D or no.
You don't like B and you don't like D. Okay. Yeah, D is definitely not it. Just as an FYI, a physician's desk reference, also known as a PDR, that's the old school Hippocrates. So remember I
Mm,
put y'all onto the app Hippocrates, but back in the day we didn't have apps. We had a big old book that was like this thick and it had every medication in it ever. That was a physician's desk reference. But
mm,
either way, nobody about to look in this big old thick book to try to figure out a pink oval small pill. So, that's definitely not the answer either.
oh,
So if you had to pick an answer, which one would you pick?
C.
All right. Ooh, they said that is it. Oh my gosh, I am so
That's what I was thinking, but
I let me okay,
I
let's
thought
go
it
through
was
these
A.
answers. The assistant should consult the physician's desk reference to identify the medication because it has a product identification guide with colors and photographs of the medication. Now that is true. I don't like the answer though. When you look in Hippocrates and you type in the name of the medication, do you remember where it shows you the pills, what the pills look like?
Mm-hmm.
So I mean, it is in there. Let's read the rest of the answers. Instruct the patient to seek help from a family member or the pharmacy. Medication confusion and errors can be extremely dangerous. Redirecting the patient could risk the patient to opt to not pursue the right answer, which will result in them taking the medication incorrectly. So, about this one, you technically could send them to the pharmacy, but they're probably not going to go, is what they're saying. Ask the patient to bring in the medication to verify what it is. Asking the patient to bring the medication into the clinic could delay the resolution of the question and is also not necessary. So long as the patient can give a detailed report of what the medication looks like, there are better solutions. And then the last one, type the patient's description into an online search engine. The internet can be useful. Searching online could, however, lead to false or inaccurate information, especially if you're on the wrong website. Um, if the web page is being used for information regarding patient care, it must be an approved site that your employer said you can use. So, I mean, you technically could use the web search engine as long as it's an approved site because it can, like, there are approved sites for physician desk reference, like Hippocrates. Hippocrates also has a website, also. But okay. So the answer is physician's desk reference, meaning you can go in the book, look up the little pill, ask the patient, hey, does the pill have a P1 and a 5 on it? Yes, it has a
Mm-hmm.
P1 and a 5. Okay, well, you only have these 10 medications on your list, so it has to be this medication.
Mm,
Which of the following is an example of a simple carbohydrate?
mm. Maybe pasta.
What is a simple carbohydrate? There's simple carbohydrates and complex carbohydrates.
I thought that's a good question. Thought it had to do with carbs.
Mhm. It does. So, I'm gonna type this in real quick for you because so there's different types of carbs though.
Hmm.
So there's simple and complex, as I mentioned. Simple carbohydrates are things like sugar, because it's basic. It's just one molecule and it doesn't need to be broken down. But complex carbohydrates are a whole bunch of like sugars and starches and fiber, and they're like built up in this chain. And then the chain has to be broken down in order to be absorbed. So, simple carbohydrates are quickly digested and can cause your blood sugar to rise quickly. But complex carbohydrates are digested slowly and they take time and they slowly release into your body to give you energy over time. So now that we know the difference between a simple carbohydrate and a complex carbohydrate, maybe you'll look at these answers differently.
Maybe honey.
Okay, let's pick honey and see what happens. Yes. Honey is an example of a simple carbohydrate because it's just a simple sugar. It doesn't need to be broken down. But actually, pasta is a complex carbohydrate because it has to be produced, right? It's not natural. It has to
Mm.
be produced and it's a whole, but so when you eat a piece of pasta, you'll be full for what, 5, 6 hours because the body has to slowly break it down. You eat a whole bunch of honey, you're gonna be hungry quick.
Oh yeah.
Beans are also complex carbohydrates, pastas are, and vegetables are. All right, we're almost done. This will be our last one. Which of the following supplements is a naturally occurring hormone in the brain that is related to sleep?
See.
Yep, C is melatonin. You want to hear a funny story?
Mm-hmm.
This nurse said that a patient kept like came into the office and was like, I've been taking this melatonin, but it ain't working. And then the lady was like, well, what do you mean it ain't working? She was like, it's not working. I keep taking melatonin. And she was like, but you so like at the visit, she was sleepy, like falling asleep. And she was like, well, ma'am, how much like melatonin are you taking? And she was like, I'm taking like 6 or 7 of them a day. And she was like, why are you taking so many melatonin? And she was like, cause I want to get my skin dark. And the lady was like, hold on, what?
Lord. Did
Girl,
she even read what she was eating?
she thought
Like,
it was melanin.
that is insane.